and sir had secured first rank in MD entrance exams in from the Manipal University. And sir has completed the fellowship from the Harvard University in the neuroimaging and has obtained European diploma in radiology and also the diploma of the ICRI in 2019. And sir has won many prizes during post graduation, including the best being the radiology review course quiz. And he is a prolific researcher with more than 100 publications in various national and international journals, and being the first and second authors in more than 35 publications. And he has also contributed for three textbook chapters and also presented in various state and national conferences. He is also a reviewer for three index journals, including the PubMed Index Journal of Neurosciences in Rural Practice. And sir has also exhibited in the prestigious RSNA conferences in Chicago and the Austria, Vienna. Sir is presently the Andhra Pradesh IIRA secretary till 27 and also the scientific coordinator for the APIIRA. He is also an AOSR and a National MR Safety Liaison and ICRI Abdominal Imaging Committee coordinator. And sir is a editor of the YouTube channel Radiology Case Videos. There are wonderful case videos on this channel. You can go and visit, and you should must visit those channels. So, sir, we welcome you all for this session. The sir's
Thank
personal
you.
area of interest is MSK imaging and the neuroimaging, and we are delighted to see the cases sir is going to present today to all the residents on the MSK imaging. So, welcome you, sir.
Sure. Please help me with as soon as I finish 15 seconds
Yes, sir. I'll
for
say more,
each
sir.
quarter. No need to remind me after 15 seconds. I'll keep track of it. And 10 spotters ke baad, we will move to the second set, something like that.
Right. Yes, sir.
Immediately, we'll stop for 10 seconds so that they can take a screenshot of all the answers. Then
Yes, sir.
I'll tell the explanations. Okay,
Right,
please
sir.
write
Right.
it
Right.
down, all the residents. And chat box is open. And unfortunately, I can't go back on any spotter because I have clearly, because we have to show more. That is the aim of the entire spotter session. So I can't go back on the thing. So at first glance only, you have to catch the answer right. Only thing is at the end, answers will be shown. What all we have discussed, I'll be showing. Okay, let's start. The first 15 seconds. I'm starting. Write down the answer. Second spotter. Third spotter. Okay, now let's
No.
see the answers. Okay, quickly you can take a screenshot or photograph, whoever is there. These are the answers which I have discussed. What my aim is that out of these 120 spotters, if you are dealing with an MSK spotter, I am damn sure that if there are 5 MSK spotters, 4 will be from this 120 which I'm showing. So they've carefully been chosen, and I'm very sure that if you can see all these 120 and learn them thoroughly, I think no beating you in MSK. That at least can be banked confidently. Let me start discussing. Scleroderma is one of the most hot favorite exam oriented question. Let it be chest imaging or let it be any imaging, like for example MSK, it may be asked, chest imaging it can be asked, and even bariums it can be asked. So that way scleroderma should be very very be confident on. So patelless GE junction, acroosteolysis, deformities, and if you carefully see here, there is calcinosis. So calcinosis is there. So this is a classical case of scleroderma, crest syndrome. You should be knowing this. Periarticular osteopenia, rheumatoid like joint erosions, and all these things are very hallmarks of. And abdomen also, you can find this classical stack of coin appearance because of smooth muscle wasting. There will be loss of subcutaneous fatty tissue. Dermis will be very thickening of the dermis will be seen. They can be associated synovitis. All these things are features of scleroderma, and the case which was shown was a crest syndrome or a scleroderma. CT is NSIP like pattern. Though I am crossing into other department, it is very very important as an exam question. It can be a short case for anybody. Patelless GE junction, patelless GE junction. So buzzword for any FSCR, EDR, MICR question, you should be knowing it. And there will be some MCTD, mixed connective tissue overlap in cases of scleroderma. You should be knowing it. So again, it's a very classical, very, very classical multiple exhaustosis. All senior examiners have this spotter with them. Why is this important? Multiple exhaustosis is normally the exhaustosis, there can be 3% chance of malignancy. In exhaustosis, it is 3%. 0.3% to 3%, that is a lot of fold increase in the chances of malignancy. Whenever you see a single sessile osteochondroma, you try to look for more sessile osteochondromas, and you can be diagnosing them. Okay, you can in if they are involving the femur, you get this typical Eller-Meyer-Fauss deformity. Then you should be also knowing sessile broad-based are more commonly associated with multiple osteochondromas. This is what is very important. Okay, key features: multiple osteochondromas from metaphysis of long bones, continuity between exostosis and underlying bony cortex of the medullary cavity. This is the buzzword. You should know continuity with medullary cavity. Then pseudo-mid-lung deformity, buzzword, very important. Then Erlin-Meyer-Fauss deformity is one another important thing which you should be knowing. Travers disease is one thing which is very important. It is also called epiphysalis hemiphilia, mostly metaphysis, but Travers disease occurs in epiphysis. And the Nora lesion is nothing but BPOP, a favorite MSK spotter, not a typical resident spotter. So this is a rare case of myositis ossificans progressiva. You should be knowing this condition, or if you somebody would have answered it as dermatomyositis or other sheet-like calcification, I will give it to them. What they should be know, this is myositis ossificans. And differential diagnosis, like you can get a localized myositis ossificans or soft tissue sarcomas, aggressive juvenile fibromatosis, all these things. It's a relatively tougher one and relatively rarer one. Don't worry if you not got it wrong, write it right. But we should know that heterotopic ossification is a broad terminology. If you write this, no examiner will definitely consider giving you marks for that heterotopic ossification, especially in paralyzed patients, hip joint, around bedridden patients. You get these massive masses around, they get so bizarre appearing. You should be always thinking about heterotopic ossification. And this is one of my favorites, vasp sign, block vertebra, omohyoid vertebra. This is omohyoid vertebra, Sprengel deformity. Klippel field syndrome with omohyoid vertebra and sphenical deformity is a classical spotter. Sphenical deformity can be seen in chest X-ray also. Be careful when there is a normal chest X-ray. Do not forget to look at the scapular heights. When definitely it will be higher. When you see a higher scapula, you should think about sphenical deformity. Wasp waist sign is nothing but the it looks like a smaller block vertebra look like that waist of the wasp. That is why, and more prone for a degeneration in higher level and lower level. So you should be knowing that very confidently. That is a Klippel field omohyoid sphenical deformity all in one spotter. Blount's disease was such a favorite spotter while I was doing examiner. Off late, it has disappeared from examiner's books, but somebody can definitely come get it. So it is a bilateral tibial vara deformity. It is mainly because of growth plate abnormality. You should not confuse with rickets or something like that. There will be other findings in rickets, not only plain Blount's disease, where there will be bilateral tibial vara. So again, there is some classification called Langenskold classification, which are describe somebody who's really enthusiastic can answer on it. And this is beak of tibia, sharp beak like medial metaphysis. You should think about, and you should be other differential diagnoses are genu recurvatum, which is the posterior tibial bend rather than medial. Rickets, trauma, skeletal dysplasias, infection, osteomyelitis. All these things are differential diagnosis. Don't answer and don't tell the differentials until they ask for. Okay, this is the classification based on this. You can read just to prime yourself with the classification. I bought this with a short note. In this short period, I can't teach you all these things. Um, and Blount's disease, scurvy, rickets, all these things you should be knowing. One Blount's disease is medial beaking and slanting proximal tibial metaphysis. In scurvy, you get this dense line or white line of Frankel, and you get these lucent tremor filled zones and pelican spur. I'm spending some time because these are all hallmarks and very, very important ones you should be knowing. And rickets is nothing but widening, cupping, fraying of metaphysis, generalized osteopenia, and rachitic rosary. This is a hallmark. This is again an osteochondroma, sessile osteochondroma. I kept repeating osteochondromas because they are very important, especially posterior spinous processes. What is happening to the spinal cord, you should always write, and thickness of cartilage cap in case of osteochondromas, you should document. Okay, and this osteochondromas I have discussed already. Coming to this is typical penicillin cup deformity. You should be able to pick up this penicillin cup deformity, and also sausage shaped disease. The disease, the soft tissue swelling appears like a sausage shape. This you should be able to pick up, and you should be documenting them. So, uh, so other key features are asymmetric joint involvement, coexistence of erosions and new bone formation, and dactylitis, and there will be pitting in the nail. Clinically they will be showing that pitting, and if you after the x-ray you can check it. And so penicillin cup in deformity occurs in a later stage of uh, psoriatic arthropathy, and other differential symmetric involvement will be there in rheumatoid, unlike the psoriatic and erosive osteoarthritis. Seagull pattern can be there. Again, classical, another benign lesion. So fingers and long bones both are common. If somebody would have written TB dactylitis, I would really consider that. But X-ray is so classical that typical chondroid calcifications within the center. Whenever there is a thinning of the cortex, you should always think about low-grade chondrosarcoma. Low-grade chondrosarcoma is a differential diagnosis. Bone infarct, bone island, chondroblastoma, all these things are differential diagnosis, but only I will consider enchondroma or low-grade chondrosarcoma for the above thing. So this again, fibrous dysplasia, you would have got it right. Shepherd Coop deformity, you would have got it right. But three images I have given. All these things you have to fuse and write the right diagnosis. This is a case of McCune-Albright syndrome, where patient had cellular mass and precocious puberty, and the patient had Shepherd-Crook deformity, fibrous dysplasia with a suspicious loser zone or a fracture, and he had a facial fibrous dysplasia extensive, giving a typical rodent faces. This is a case of McCune-Albright syndrome. The one clinic sign they will have is cephalate spot. Cephalate spots will be there, and multiple endocrinopathies, asymmetric skeletal involvement, polyostatic fibrous dysplasia, ground glassing. All these things are features of uh, case of McCune-Albright syndrome. So this is a case of Paget's disease, where you can see that picture frame vertebra. It looks like a picture frame, and this is mixed lytic sclerotic phase, where there is a thickening of iliopectineal line, and there is amount of sclerosis, which is classical. Lytic lesions are thin. Skull also is there thickened, and in this case, the basilar invagination was absent. This is even the coccygeal vertebra and lumbococcygeal vertebra are involved with mixed lytic sclerotic phases. So, cotton skull will show cotton full appearance, spine will show picture frame, pelvis will show thickening of the iliopectineal lines, and long bones will show bowing deformity. They can also be blade and grass appearance of the long bones. All these things are classic phases of Paget's disease. All the 10 I have shown are short notes. All the 10 I have shown are classic spotters. You should be knowing them very carefully. Most commonly, osteoblastic metastasis or a metastatic bone disease or FDA is the closest differential diagnosis for the Paget's disease. You should be knowing them. Okay, let's go to the second set of the spotters. I'll start counting the time. People are answering well in the chat box. I think it's better to write down paper unless and if you have time, then answer in the chat box. That will be useful because you can review your answers. Very good, Apurva Thakre. Really good. You've been on the toes. Other participants don't see the chat box. A young child. If I give the answer as a young child, what can be the differential diagnosis? But Radio Sapien is answering well. Okay. Sahiti is answering well. Easier ones. So many to see. Sorry if I'm fast. I can't help because in short period I have to cover so many. Very good. Excellent. This is yeah. Okay. Chat box became silent for this. Two people are waiting in the room. Somebody can admit him.
Yes, sir, done, sir.
Oh,
Already.
sure. Great. Okay. Somebody can take a shot of screenshot of this 11 to 20. Oh, all these things are short notes: multiple myeloma, brown tumor, Marcos syndrome, osteodystroma, LCH Maffucci syndrome, melanostosis, Ascut-Sartor, sclerocranial dysplasia, and diaphyseal achalasia. The first one is so classical. This is a case of multiple myeloma, where you can see that punched out lesions. And if you carefully see, there was mandibular involvement in this case. The bones are so osteopenic, there is a collapse of it. And Subsequently, all the features you should be in multiple lytic lesions with punched out or moth-eaten appearance, vertebral compression fractures or fish vertebra, overall diffuse osteopenia, and all the spine, pelvis, ribs, long bones are affected, giving a typical soap bubble appearance, and risk of fractures is high. So one thing they'll ask is the mandible involvement in metastasis is rare compared to multiple myeloma. This is one thing you should be knowing, and they will be asking how will you differentiate metastasis from the multiple myeloma. So this is again a sisterly case of multiple myeloma. This is a case of hyperparathyroidism with parathyroid adenoma. You are seeing brown tumors. There is some degree of acroasterosis. There is typical pepper pot skull, and you should be also looking at the lamina dura lack of ossification. You can see loser zones or pseudo fractures, and diffuse osteopenia in a case of hyperparathyroidism. So I've discussed in detail all the imaging features you should be knowing, and so this is a case of, somebody is rightly pointed, the case has a central beaking. So this is a case of Marquez syndrome, and bullet shaped metacarpals also are seen. Central beaking, so you remember Hurler's is superior beaking, inferior beaking, then superior beaking can occur in other mucopolysaccharides. All these things are important. You should know. You read about what type of beaking they'll definitely ask in the exams. And Marcos syndrome, there will be patty spondyli, and spine, long bones, pelvis, ribs, everything will be involved. And you have to differentiate it from other skeletal dysplasia. Okay, you get a J-shaped sella turcica, and macrocephaly you will get in Hurler syndrome. There will be broadening of the ribs, or paddle or oar-shaped ribs will be seen, and they can be associated odontoid hypoplasia. And in Hurlers there will be less cervical spine involvement. In Hurlers there will be anterior inferior, and in Marquez there will be central and anterior beaking. So these are somebody may ask you in the exams how will you differentiate both of them, and you should be able to answer them. Okay, these are all classical exam questions. This is one of the hot favorite exam question. Osteoid osteoma, you go across every platform, MICR, FICR, you'll get the question, and they will end the question saying, what will you do with this patient? And what is the size of the lesion? Size less than 1.5 centimeter osteoid osteoma, greater than 1.5 osteoblastoma. Intervention question will be there regarding that, and subtle metaphyseal lesion in a femur is a most common question, important, which is very important. Okay, this is regarding the osteoid osteoma. So rightly, somebody has answered as a arthritic encephalocele. I will give it to him because it is a very close differential diagnosis. But this was a case of proven LCH. Other systemic manifestations were there, and eosinophilic granuloma. Age given, especially very young age, less than 5 years, or maximum until 20 years, you can consider that differential diagnosis of eosinophilic granuloma. And again, eosinophilic granuloma or LCH, they'll definitely ask the findings of chest, long bones. These histocytosis like Ederheim's chestus disease. All these things are very hot favorites in especially Western exams. Vertebra plana will be seen, which is most testing young child with vertebra plana. They'll test you whether you are answering metastasis, or are you answering some tuberculosis or something like that. But young child with vertebra plana always answer LCH. They'll be really happy in exam. The kid will have floating teeth. That you should clinically, there will be some degree of history given, especially if you are writing for any Western exam. You should think about it. Then coming to the there will be beveled edge skull lesions and floating teeth in mandible, vertebra plana. There will be multiple system involvement in a LCH. This is classical. I don't want to waste any time. You will be seeing very classical multiple enchondromas with hemangiomas, Maffucci syndrome. Nothing much to tell in it. And phlovoids, these are nothing but phleboliths of hemangioma. Classical dripping candle wax type appearance. Dermatomal involvement is very important. That one question they can ask. This is a case of melanostosis. Other differential diagnosis in a melanostosis are They can be associated. Uh, they can be Camurati Angelman's disease. They can be you can get other sclerosing dysplasias like osteopoikilosis. This is Chapman question. Write all the sclerosing dysplasias. You should be able to write all the sclerosing dysplasias when somebody asks you. Even differential diagnosis, Paget's disease, but this is very classical. What is this? This is they have answered confidently. This is a classical case of Osgood-Schatter's disease, fragmentation of the tibial tuberosity. Ultrasound can diagnose it very confidently. It is common in adolescents, especially involved in running and repetitive knee movements. We have to differentiate it with fractures and patellar tendinitis. So this is a classical case of Osgood-Schatter's disease. Somebody should have picked up this absent clavicles and Vermean bones. These are Vermean bones, classical. If somebody would know, and widened fontanelle. This is a classical case of cleidocranial dysplasia. And people will ask you, sorry for this wrong. I wanted to keep a differential diagnosis of cleidocranial dysplasia from the pycnodysostiosis, where acrodiastolysis and hand findings are more commoner in pycnodysostiosis compared to the cleidocranial dysplasia. And here, if you see carefully, what else is there? What is this? This is again another case of diaphyseal achalasia, repetition. I agree. I've discussed in length and breadth of diaphyseal achalasias. Again, here I am showing you the pseudo Madelung deformity, which I was telling earlier. This is a pseudo Madelung deformity. It's not a true Madelung deformity. Okay. And this is word you remember, coat hanger type of exostosis, very small sessile enchondromas. Again, osteochondromas look like a coat hanger exostosis. Osteochondromas. Yeah. What is this? Yeah. Sahiti and Radio Sapien are really competing to answer. Very good. A lot of videos on this syndrome in my radiology case videos. You can log in. It may help you for your exams. ಯಾರು? Yeah, yeah. You can write down the answers. Just take a screenshot what all I have discussed. The, these are relatively not related to MSK, but they can be asked in the other fetal radiology or something like that. I believe this and these were the toughest among all, because in vertebra plana generally you're used to seeing in a size. This is a classical Sever's disease, nothing much. Calcaneal osteomyelitis or there will be osteochondritis, apophysetic, calcal apophysetis because of mild fragmentation, irregularity at the insertion of Achilles tendon. And this is nothing but a classical glomus tumor. Very painful nail bed tumor enhancing is a glomus tumor. So this is a classical Eagle syndrome. You all know enlarged styloid. Right now they have increased the cutoff to 3.5 centimeters. Earlier this was the older cutoff. Still clinically, if it is relevant, you can definitely answer Eagle syndrome. So this is a very, very hallmark. Two locations, clivus and the sacrum. Okay, so sacrococcygeal chordoma, very T2 bright lesion in the sacrococcygeal region. Incidentally, there was also a Tarlos cyst in this case. Okay, differential diagnosis important. Chondrosarcoma, definitely not GCT, it won't be so bright. So chondrosarcoma, I will definitely consider as a differential diagnosis. Large destructive sacrocaudal mass, this can be lobulated pseudopodia-like appearance. This is one buzzword which you should be knowing. Okay, sacrococcygeal. So this is a distal, bilateral, lateral clavicular erosions. They can be seen in case of hyperparathyroidism, rheumatoid arthritis. Then there will be generally preservation of acromion. There can be subchondral bone resorption, scleroderma, pycnodysostiosis, and rarely progeria. All these things are differential diagnosis. You should be knowing about bilateral, lateral. First thing is rheumatoid. Young person, when they come, it is a rheumatoid arthritis. So this is a case of vertebra plana. Relatively, people didn't answer that well. They thought it is a oval eye. Yes, I will give it to you. When somebody said oval eye, this actually collapsed. Both eyes are gone. It's not oval eye. Oval eye or winking oval is single eye, and 70% of reduction only. Then only you should call it as vertebra plana. Uniform flattening is there. So kyphosis angle also will increase greater than 15 degrees. All these things are differential diagnosis. You can take a screenshot if you want. Vertebra plana in detail, Langhans sisters, metastasis, infection, lymphoma, trauma, multiple myeloma, hemangioma, osteoblastoma. An enthusiastic examiner may ask you at least tell 5 causes of vertebra plana. Deep sulcus sign, whenever there is a ACL tear, there will be pivot shift marrow edema. One edema will be in the posterior lateral corner, and another one in the anterior aspect of the lateral femoral condyle, giving a typical deep sulcus sign, ACL tear sign. This is so this you should be knowing. It's also called a terminal sulcus sign. Pivot shift injuries are the common. This is relatively tougher one, acromegaly with a spade of tufts sign. These are the tufts which you are seeing. So again, dense sclerosis, you're seeing acromegaly, good density will be maintained. You should be knowing spade-like or a tuft-like. In patient will get premature mandibular enlargement, premature osteoarthritis, enlarged sella turcica, pituitary adenoma, phalangeal tufts. All these things are features of classical acromegaly with spade of tuft appearance. Amniotic band syndrome, nothing much to discuss. The bands will come. There can be amputation of any part. It can be whole limb also. You should know the clinical history. Ultrasound, it's more of an ultrasound diagnosis nowadays. It was a old time spotter. That's why I got this. So this is a case of amniotic band syndrome. And also this is an multiple, there can be multiple associated uh, uh, contractures. So this is a case of arthrogyroposis, fixed contractures involving knees and elbows, antenatal diagnosis rather than a more of a internatal diagnosis. Okay. So next set of spotters. Nobody got it right. I'll spend some time on the spotter. Okay. Okay. These are the answers. People were answering this session very much better than earlier. Maybe you all didn't do well in congenital syphilis, which is a tougher one, and also intracortical hemangioma. Others, you are all doing extremely well, and you had tough problem with decurrent stenosynovitis, which is a MRI. You need multiple planes. I agree. So clinical history is also important. So these three were the toughest one for all of you. So this was the case of congenital syphilis, where you get this periosteal reaction along the diaphysis. You may also get some similar to scurvy. You get this Wimberger sign. So ultimately, whenever you get periostesis along the multiple bones, you should think about congenital syphilis. Nowadays, it's almost disappeared. Old time spotter. Don't worry about it if you don't know. That's okay. And this is a metaphyseal corner injury. Where somebody was answering it as very important in a non-accidental trauma. Somebody answered it as some rickets or scurvy. No, it is, you have to, whenever there is a metaphyseal corner injury, you should think about a battered baby syndrome. So differential diagnosis includes rickets. I agree, but first thing you have to think about is battered baby syndrome, non-accidental trauma. Cotton wool Paget's disease already discussed in length and breadth. We'll skip that. Paget's disease and cotton wool. Other thing is you also get this osteoporosis circumscripta in case of Paget's disease, which is also, so in skull you get sclerosis, cotton wool, osteoporosis circumscripta. Okay. So this is a nothing much to discuss. The first compartment tendons will be uh, really involved. So you get this typical lotus root appearance on short axis imaging on ultrasound, and thickening and edema in the first dorsal compartment sheets, peritendinous edema, increased vascularity and Doppler imaging, possible septations of first extensor compartment, reactive adjacent bone marrow changes will be seen in a decurrent stenosynovitis. So dish, everybody's favorite, multiple segments, thickened osteophytes, bridging osteophytes. These are classical. All of you got it right. So not a difficult spotter at all. I'm skipping this and discussion you can read. Angst-Pond is one differential diagnosis you should be knowing. And this is a tough one which you all had difficulty. It's a dysplasia epiphylosis hemimelica, osteochondroma of epiphysis. Osteocartilaginous lesions from the epiphysis, typically affecting one side of the joint, predominant involvement in lower limb, especially ankle, knee, foot. So I saw classical case of osteochondroma traverse disease. So extramedullary, all of you got it right. This typical Rib widening you have picked up, excellent. And you can also see some degree of masses, ping pong ball like masses in a EMH. Parametrial masses without bone destruction, hepatosplenomegaly, chronic anemia, thorax, liver, and spleen will be involved. It resembles a malignancy. Excellent. I was very impressed by the way you answered. Seagull erosions or erosive osteoarthritis. You have not fallen for a trap of rheumatoid arthritis or anything. Gull wing erosions and sawtooth deformities are classical for erosive osteoarthritis. Excellent. Central erosions in the interphalangeal joints, predominant involvement, distal and proximal, relative sparing of MCPs, inflammatory symptoms of affected joints, rheumatoid, psoriatic, osteoarthritis, and gout are the other differential diagnoses. So green stick fracture, somebody was answering as a torus fracture. I wouldn't give it to them because it's one side cortex is intact. Torus is more of a buckling type of fracture. Green stick is a one side cortex will be broken compared to the other side. You should be specific, and so it generally affects radius and ulna. Angulation of fractures will be seen. Last one is that pattern is typical Antimony approach, nothing much to discuss. It is more of a cortical lesion. If you see this typical intracortical osteolytic lesion with trabecular, you should always, wherever you see skull hemangioma, I have a beautiful case of skull hemangioma and radiology case videos where you get that typical trabecular pattern. If you can see that, you can diagnose it very carefully. Okay, then okay, next case, next set of cases. Yeah. Sahiti is answering very well. Good, Sahiti. The bone is navicular, I agree. It's okay. If you see the answer also, take a break and answer, no problem. Sometimes an examiner can get you a very bad X-ray, so be prepared. Not all will be very beautiful. Dear Kapil,
Sir.
dear Kapil,
Yes,
hello.
sir. Yes, sir.
Can I do 60 each for each day? I just got. So can we take one more day or one more hour, some other day?
Yes, sir. Yes, sir. Yes, sir.
I think
No
I'm
problem.
not able to do justice for the amount of spotters I'm doing. I'll stop at 60, I believe, today,
Okay, sir. Okay,
and
sir.
uh, rest we can do in one more hour. I'll take
Yes,
maybe
sir. Yes, sir.
once they finish their curriculum without disturbance. I'll take.
Yes, sir. We will adjust
I
it,
think
sir.
the DNB exams are when,
It is on, I think, 12th and 13th, sir.
so we can be as soon as once your sessions are done, I'll take the next
Ye-
60
Yes, sir. Yes,
because
no
I'm going
problem.
too fast. I think they may not be able to catch.
Sir, sir. Right, sir.
Sir. small. Yeah, take the screenshot. You're all saying somebody jumpers knee you had difficulty. So you have to focus more on the patellar tendon. Only at the last moment when I have drawn the answer, you shot. And Collar's disease, you are able to identify the navicular. Immediately you have to shoot. Arrow was pointing. And Kamal's disease was directly given the answer. It was more of an internet picture. Lachnar's curve, it's a poorly exposed radiograph, but still you should be able to identify the copper beaten or Lachnar's skull. Somebody has answered. These they are good answers. And this I was surprised that this is a hot favorite for an MSK radiologist. Liposclerosing myxofibromas LSFMT. This you should be knowing it. Then lunate perennial dislocation. This is a concept to be learned, but this case which I have shown is lunate dislocation. And mallet finger you should be knowing. And MCL avulsion was not Pellegrina. It was an MCL avulsion fracture. And the last one was a medullary bone infarct. So here, if you see, ultimately they got it right. So this was a typical patellar tendinosis, and I published one case. There was also a cyst in case of a sailor who was jumping on the dashboard regularly as a part of exercise. So there will be cyst formation subsequently, and it will start here. It's a case of jumpers D. Soft tissue swelling around the inferior pole of patella. Uh, Proximal third of the patellar tendon thickening with altered signal intensity, absence of inflammatory cellular inflates, associated repetitive jumping or high part injuries, progressive symptoms correlating with definite imaging severity. So somebody said it is a Sinding Larsal, that is inferior patellar, occurs in a younger patient. This was skeletally matured patient, so it is not a Sinding Larsen disease. So jumper's knee or patellar tendinosis, you should be knowing. So this is a hallmark and classical Kohler's disease. And you should be able to tell all the avians. I think maybe next class I'll add up a slide where I'll get one or two more avians, and you should be able to answer. Uh, Somebody can answer what is Preiser's disease. Next, they can answer for Preiser's, Pressers, Preiser's. Chat box. Okay, somebody is answered, but I'll keep this for the next class. So they should all attend, and I'll tell you. Okay, then this is again a avian of vertebra, where there will be air within the. This is nothing but a nitrogen gas. So delayed post-traumatic vertebral collapse following a minor injury. Initial asymptomatic period followed by progressive kyphosis. Most commonly affects T8 to L4 value, associated osteoporosis and other risk factors of avian. You should be ruling out. It's not an infection. So lacunar skull, it is copper beaten, congenital ossification defect, fenestrated appearance of the skull, more pronounced involvement of inner table than outer table, often associated with neural tube defects, but can be an isolated finding. May persist into adulthood in some cases. Normally, sometimes vitamin deficiencies and raised ICP can cause copper beaten. That is more of a acquired, and this is a like what we are talking about is a congenital ossification defect. Almost patients with idiopathic sclerosis, there will be 15.2%. So this is an copper beaten. Somebody who has answered copper beaten, it is not a primary bone defect. It is more of an ICP increased defect. Other craniosynostosis can be a questions. You should be really be ready. Liquid candy stick appearance, hallmark pattern, nothing much. It's more of a neuropathic joint. Neuropathic joints occurs in Lisfranc location and also intermetatarsal. Neuropathic joint in leprosy most commonly occurs in the intermetatarsals and interphalangeal joints. You should be able to diagnose them confidently. So concentric bone resorption of the phalanges result in tapered appearance, characteristic liquid candy stick appearance of the affected digits associated with advanced lepromatous leprosy. often accompanied by soft tissue atrophy and nerve thickening. Progressive deformity leads to the stubby digits. So other differential psoriatic arthritis. I would definitely give it to somebody who answered as psoriatic arthritis, especially at the fingers. Though both look very similar. Others I don't buy it. So psoriatic arthritis. So this I said this is an antimony. Remember, if you Google it and see, this is a typical location of liposclerosing muco. MRI will definitely help us. Strong prediction for proximal femur, typical location, and typically occurs in fourth decade. Well-defined lytic lesion with sclerotic margins, and very small risk of malignant 10 to 16% necessitate the follow-up. This is LSFM. Whoever don't know it, just know it by now. So the LSFMFT. So this is a case of a lunate dislocation, and this is where in our case the cup has gone out. In perilunate dislocation, it will be posterior, and lunate dislocation is anterior. This is what you have to be very sure. Have this pattern. Take a screenshot. Somebody has answered still in confusion that in lunate dislocation, the lunate will be dislocated. In perilunate dislocation, other things than lunate will be dislocated. There is no fancy funda in it, and it is more of a posterior. You remember that. Okay. Then this is character spilled teacup lunate. Remember this for today. From today, no confusion. Spilled teacup in case, and again they can be a volar displacement of the lunate, and triangular piece of pie sign of lunate also can be seen in AP view, which you should be knowing it. Lunate maintains articulation with radius and capitate, which are displaced dorsally in a case of perilunate. Somebody has asked beautifully, midcarpal dislocation involves the disruption of lesser and greater arcs without lunate dislocation. It cannot be Anup Pathani, it cannot be midcarpal dislocation. In a scapholunate dislocation, you get this typical Terry Thomas. There will be widening of scapulohumerate interval. So again, triquetral dislocation, wrist fractures can have, and the arcs of gilula will be disrupted. So this is why I just said I can't give so much of time for each spotter, Kapil. So I'm glad that you have given me more time. So this is very important. Somebody can take a picture from today. No confusion. Lunate and perilunate dislocation. This slide alone will help you diagnosing all the dislocations around the wrist joint. Important FRCR, MICR, EDIR, DNB, MD exam question. And this is typical antimony mallet finger. And when there is a avulsion injury, you should inability to actively extend the distal interphalangeal joint, and the fingertip resembling mallet or hammer. It is caused due to direct DAP joint direct trauma, can involve tendon rupture and avulsion, requires timely treatment, and so that is a typical mallet finger. Uh, they can be avulsion. So this is again one more avulsion where there will be uh, MCL avulsion injury. Grade 3 wavy appearance will be seen. And Pellegrina stidea, there won't be any bony defect. It will be just an ossification of the MCL. Somebody has answered as Pellegrina stida. So that is again very, they know the, so you should be little careful, and you should be answering it. Okay. So last one is medullary bone infarcts. Post-COVID, there is such an increase in medullary bone infarcts. We were seeing it so commonly. You should be knowing it very, and you should answer it. In long bones, when you see a geographic pattern, especially, you should definitely diagnose a case of medullary bone infarcts. Okay. So these are all characteristic double line sign in a medullary cavity, diaphysis and metaphysis. 50% of the cases, it can be symmetrically involving, and significant delay between infarct and radiographic signs. Patient will have, especially in sickle cell disease, they can be lot of it. And X-ray enchondroma can be differential diagnosis, not an MRI. MRI enchondroma picture is completely different, and X-ray enchondroma and bone infarct anastosis can look similar. Okay, we'll go to the next set of maybe last for the day. Actively answer. So not a classical one, but borrowed slide. Five minutes to buy laptop. Impressive that the people are answering Nora. The problem is like people who are all answering Nora should also be answering Ricketts very well. Impression. Kruba Jabraj, very good. Ochronosis, hemangioma, good. Sorry. Very impressive. Yes. Okay. The first few ones were really difficult. I totally give it to you guys. They were really challenging. Multiple NOFs, Jaffe Campanasi, multiple epiphyseal MED, and metaphyseal chondrodysplasia. And BPOP, you all got it right. Ochronosis, these were all simple. Osteofibrous dysplasia, osteoporosis. So it is all a balance. Always 7 out of 10 will be easy, and the three are really challenging. One or two you do common mistakes, and most of the average students like me get 6 out of 10. So you also should attempt to get 7 out of 10 or something like that. Don't get disheartened by the one tough spotters. You have to move on and answer the rest. So whoever have got disheartened with the first two, three, wouldn't have answered ochronosis, intraosseous hemangioma, fibrous dysplasia, and osteopathy. And the last one is the gout. So this is a case of metaphyseal chondrodysplasia where there will be abnormal metaphysis. Patient will have this bowed legs, genu varum, short stature, coxa vara, characteristic metaphyseal changes. It's an aunt mini, nothing much. And also metaphyseal flaring will be there. Enlarged knobby metaphysis. See, this is what I was trying to show, knobby metaphysis and splaying of metaphysis in the proximal femur. So these are all characteristic features of metaphyseal chondrodysplasia. And this is again MED, epiphyseal dysplasia. See the irregular abnormal epiphyseal dysplasia. Also, you get this delayed epiphyseal ossification centers. You get coxa vara, and you get this snow cap appearance. All these things are these are all rare. I think you'll be lucky enough. I think you'll not get it anywhere nowadays. They're like relatively rare spotters. They're not asking it that often. But you should be knowing whenever there is epiphyseal destruction, think about chondrodysplasia punctata or epiphyseal dysplasia, MED, you remember. Okay. Delayed appearance of epiphyseal ossification center. So Jeffe, multiple knobs is Jeffe Campanazi, one of my favorite spotter. I'll be definitely asking. See, knobs, sclerotic rim, eccentric location, definitely not a malignant or a process. So this is also somebody right. It's associated with NF1. Good. That's definitely right. So multiple non-ossifying fibromas, primarily affecting. They can be capillate spots in skin, possible giant cell granulomas in the jaw associated with extraskeletal manifestation cardiovascular. Differential diagnosis, as Saiti said, is NF1, and also FDs, multiple FDs is called polyostotic fibrous dysplasia. Multiple myxomas, where will you get multiple myxomas? Yes. So all these things, multiplicity is one of the favorite questions which examiners will be asking. You should be answering them. So, and this is a case. See, the bones are all good, but you get this Ackermann zonal phenomena. This is a case of myositis ossificans, and you get this radiolucent string sign, and you can get this zonal phenomena with peripheral ossification. Typical location, large muscles, history of trauma, most of the cases, which was not given to you. That is why it was a challenging spotter. It's self-limiting condition. If huge masses should be operated. Okay, striate appearance, checkerboard pattern, zonal phenomena, string sign. All these things are hallmarks of myositis ossificans. So first zone is peripheral hypoechoic zone on ultrasound, middle hyperechoic zone, and three central hypoechoic zone. So these are the features of zonal phenomenon of myositis ossificans. This they all got it right. Most of the people got it right. Called Nora's lesion or BPOP. So benign abnormal osteochondromatosis proliferations seen along the metacarpals, well marginated, wide bony growths, dense mineralization, lack of medullary involvement are hallmarks of BPOP. Typically affects hands and feet, phalanges, metacarpals. Peak incidence is third and fourth decades. Differential diagnosis, periosteal, parasteal osteosarcoma and osteochondroma. Ochronosis, yes, disc ossification, ankylosing spondylosis, ochronosis, very common disc ossifications. In this case, you are able to see the air and narrowing calcifications, multiple vacuum discs, flattening of lumbar lordosis, all these things. And as I said, the first one is calcification pattern will not be so classical. It's not all or none phenomenon. You can see some degree of calcification. Angstpond, you keep it as a closed differential diagnosis. Only thing is bluish black discoloration of connective tissues will be seen in ochronosis. Okay, alkaptonuria will be seen, so it's easier if the clinical history is given in cases. And intraosseous hemangioma, you get again trabeculated repetition, and I'm glad if it comes as an exam spotter. Typical trabeculations and polka dot and you get it in spine, polka dot. Slow growing benign tumor, vascular origin, 0.5 to 1% of osseous tumors. Most commonly affects calvar and vertebral column. Fibrous dysplasia, osteoma, Langerhans cystosis, multiple metastatic disease, all are a differential diagnosis. But I believe none are differential diagnosis. Whenever you get that cortical trabecular pattern, typical radiating pattern, it's nothing but intraosseous hemangioma. Absolutely right. Fibrous dysplasia. Closest differential diagnosis in adults is adamantinoma in tibia. Tibial lesions, always remember commoner adamantinoma in adults and FD in relatively younger people. So this you should be knowing it. Adamantinoma, more aggressive features, similar location, and osteofibrous dysplasia, anterior cortex of tibia, and you should be knowing that it's a difference from fibrous dysplasia is more centric and cyst formation. You can see fluid levels and MRA interchangeably used, but somebody may ask you, is there any difference? Then you should be able to answer it smart. Nothing much I can tell you. Striated pattern, osteopoikilosis, osteostriata, dermatomal distribution again. You can linear striations, sclerosis, often asymptomatic, incidentally seen. As I said, more aggressive sclerotic pattern, malorostosis, osteopoikilosis, you get this oval sclerotic. You can get this mixed sclerotic bone dysplasia in most of the conditions. Okay, this was again one of my uh, classical um, uh, exam question where you get these overhanging edges. Here you are seeing the overhanging edges, and you are seeing the soft tissue. So multiple soft tissues you are seeing. So this is a classical case of doubt. Soft tissue masses are tophi. There is first metatarsal phalangeal joint involvement. Dual energy CT is very useful. Punched out lesions can be seen. So MRI, T1 intermediate, T2 variable. These are the features of uh, gouty tophi. You get in ultrasound, you get this deposition of crystals will give this double contour sign in ultrasound, and erosions can be seen in two planes in a case of gout. Uh, Sahiti is asked, why is it not FCD, sir? In which one? I think, did you ask about this? No, it is involved in through and through. FCD is more of a cortical lesion, one side eccentric location. Um, I think it is involving metaphysis. It is involving the other cortex. So not a fibrous cortical disease. It will be giant enough, more eccentric, more towards cortex, and more sclerosed is FCD. Right. This is what you have to know. Thank you, Kapil. And sorry, I overestimated, and I thought I can finish 120, so I could only
No
clear
problem, sir. We'll adjust in some other session,
some
sir.
other session.
Sir.
And maybe Friday they have class.
7 days, sir. Till Sunday, we are actually planned.
Saturday. Okay. Yeah, then Monday I don't have any issue. Like I can take it on
Yes, sir. Yes, sir.
Monday
We'll
or
plan it.
Tuesday. Monday or Tuesday we can plan. Sure.
Yes, sir. We'll plan
Thank
it, sir.
thank
Thank
you
you,
very
sir,
much.
for such a wonderful
Sure.
set of spotters and such a great variety. And
Sure. Thank you.
I'm
That's
sure, sir.
these all
Thank
not
you,
needed. It's my passion, and
sir.
I can help residents anytime.
Yes,
If
sir.
any if you just go through the chat box, if I have not answered anything, please post me. At the next
Yes, sir.
time,
Yes,
I'll definitely answer. Thank you.
yes, sir. Yes,
Thank
sir.
you. Bye.
So we can conclude the session, sir,
Yes,
right
yes,
now.
yes, yes.
And tomorrow, at the same time, we'll be having a neuroradiology session by Dr. Satvir Chaudhary, sir. So all the residents, please be on time for the session. So that's all for today. I'll take good night.